and let's get started. Thank you, everyone, for joining us for this November 2023 BrainX Community Live event. We are very excited to have you here, and it's a very exciting session, something that I've been looking forward to for quite some time. But for those who don't know about BrainX Community and joining us for the first time, we started this platform 5 years ago. That picture is from the very first meeting that we had that used to be in person. And it's been 5+ very successful years, 5,000 plus international member community and a very diverse community. We have a very active LinkedIn group with 2,700 plus members and growing. And of course, our website, brainxai.org, you can go there. You can find recordings of these sessions, and you can get so much more scientific information related to AI in healthcare. That is what we are focused on. And of course, we do these monthly live sessions to bring everybody together to share scientific knowledge about AI in healthcare. This is our website, and there are a lot of features on there that I'll quickly go through. The update section to stay tuned about the latest updates, the next upcoming programs, the podcasts and all, you'll find those there. We have the connect section there where you can find the knowledge about upcoming sections, the speakers, and also the recording of our prior sessions, which are hosted on our BrainX Community YouTube channel. And if you want to catch those, subscribe that, you'll get an email as soon as it's posted, and you can watch the prior recording that way. As I mentioned, a very active LinkedIn group. Please join us there. Please participate in that. We share a lot of scientific information related to AI in healthcare. And we have our Learn section, which provides a curated list of articles, journals, books, and courses. And recently, we have even added a filter in there for large language models because those publications are growing. They're linked, they're categorized for different healthcare specialties. And as I mentioned, there's a filter option. So if you want to look for cardiology or if you want to look for imaging, any of those healthcare specialties, you can filter those and go directly to the healthcare specialty AI learning of your choice. Data has been something that everybody has been asking for. So we have the largest repository of open source data sets to get your machine learning quest going. They are also filtered by topic. So you can look at different healthcare segments and find the data sets that are open source that require minimal DUA and get your machine learning model going based on that. We have our podcast series where we have featured, actually a lot of panelists today have been featured on our podcast series, and you can learn from their experiences, how they grew in this space, what is their vision for the future. So subscribe that on your favorite podcast channel, and you can listen to their experiences there. And as the meetings and conferences are coming back after the COVID-19 in person, we want to connect with you. We want to join you there, figure out opportunities to collaborate and share scientific information. So if you want to know where is the next, latest, and the greatest AI in healthcare conference, visit our meetings and conference section within brainxai.org, and you'll find that over there. And with that, I'm going to invite Jennifer Owens to moderate this session. We have Dr. Pallavi Tiwari, who's joining us. We have Dr. Reem Khatib, Dr. Shreya Mishra, and Dr. Lama Nazer, who are all joining us. Exceptional women in leading healthcare application in AI. Very thrilled to have them over here. And Jenny Owens is going to moderate that for us. And she has been working in healthcare and healthcare IT for quite some time. She has an awesome podcast series called Health Data Ethics. So if you haven't heard about it, please join that on LinkedIn. You can follow her, and you will learn a lot about her work, her inspiring vision for the future, and listen to others too. And with that, I'm going to turn it over to Jenny Owens.
Excellent. Thank you so much. I really appreciate it. Can we do just a real quick round of introductions so everybody knows who our speakers are? I know we've got bios up on the screen, but it might be helpful to match faces and voices with the bios. Dr. Tiwari, do you want to start?
Sure. Thank you for having me. My name is Pallavi Tiwari. I am an associate professor in the departments of radiology and biomedical engineering at University of Wisconsin-Madison. And my research for the last 18 years or so has been focused on developing artificial intelligence and machine learning approaches in the context of oncology and neurological disorders. Looking forward to our conversation.
Excellent. Thank you. Dr. Khatib, do you want to go next?
Sure. My name is Reem Khatib. I'm an anesthesiologist at the Cleveland Clinic, and I also serve as the IT medical director for anesthesia informatics. So I come from this more from an informatics type of standpoint. I'm looking forward to the discussion as well.
Excellent. Dr. Mishra.
Hi guys, I'm Shreya and I'm a postdoc at Cleveland Clinic, and I did PhD in computational biology from IIIT Delhi, India, and I work on in genomics, and I work in genomics and AI in healthcare with BrainX. Thank you.
Excellent. Dr. Nazer.
Hi, everyone, and thank you for inviting me to be part of this panel. My name is Lama Nazer. I'm an ICU clinical pharmacist at King Hussein Cancer Center in Amman, Jordan. And I'm also the clinical affairs manager for the pharmacy department. As far as AI goes, my involvement has been primarily over the past several years with AI specifically related to critically ill patients and cancer. I've been looking at other aspects that's primarily my focus of research in terms of healthcare and AI. And again, it's a great pleasure to be here.
Yeah. So we kind of collected our questions into a few key topics. I don't know, Dr. Mather, do you mind advancing the slide? We can talk a little bit about training first and foremost. Training in healthcare AI is a complicated topic to begin with, right? But I found it really interesting because I was unaware of how underrepresented women were in data science and related areas. So less than 20% of students, less than 10% of decision makers. And there's a fantastic group called Women in Data Science Worldwide that is aiming to increase that representation up to 30% by 2030. So to do this, they offer conferences, they have an ambassador program, and they do upskill workshops for those who want to add some data science skills to their resume. So as I've been working in this space, what's really stuck out to me is that it's difficult to train in artificial intelligence and machine learning and data science and medicine at the same time. There aren't a lot of formal programs that are going to offer you that sort of hybrid training. So for our panelists, I'm curious to know, how do you approach learning in fields that you haven't been formally trained in? So if you're primarily, a machine learning or an artificial intelligence trained person, how have you approached gathering the healthcare information that you need, and then vice versa for our clinical folks? I don't know if anybody wants to jump on that, or I can call on people.
I can talk a little bit about my experience in terms of trying to learn AI, even though it wasn't part of my formal education. Sure. And I think for a lot of us, maybe the newer generation, things are a bit different because AI is becoming more integrated in the education and the training of a lot of healthcare fields. I think for the not so new generation, it wasn't part of our formal education and it wasn't part of our formal training. So trying to learn it as we go through our career, it becomes more challenging. The part that I find very helpful with AI in healthcare is that we're almost all in the same boat. The majority of us are learning this as we are progressing in our careers. And there's a lot of resources that are available, some that are very reasonably priced, some that are free. There are a lot of different formats, some that are more structured, some that are less structured. But there's a lot of different resources that we can use and that we can utilize to really help us develop those skills. The other part that's been very helpful is the way, for example, research in healthcare AI works, is that you really need to have a diverse team to really have an effective research in healthcare AI. And that team needs to include a diverse group of data scientists and clinicians and people with different backgrounds and different levels of seniority. And that really helps with the learning process. So there's so much that we learn from our data scientists. There's so much that the data scientists learn from us. And it's really a learning path for all of us that as we are building AI in healthcare, it's also a learning process. So that's kind of, how things have been in terms of my learning curve with AI in healthcare.
So maybe I can add on to that and provide the alternate side of things. So I'm actually one of the rare few that you mentioned on the slide who are trained in AI. Well, not in healthcare, but definitely I have training in AI and machine learning. So my degree is in biomedical engineering, which allowed me to appreciate the fact that you need to have engineering training, but also have close bonds and close connections, collaborations with your clinical collaborators, like, was mentioned by the previous panelist as well. It's because the field is growing and it's so diverse. From my perspective, one thing that was a learning experience, and I still learn on a daily basis, is to make sure that we understand the clinical questions, right? Because you can only develop solutions if you deeply understand the question. What is the problem that the clinicians face on a daily basis? And you don't always need the fanciest AI machine learning solutions to solve the problem. It could often be a simple solution, and that does the trick, right? So just understanding the clinical questions, and that really helps when you sit down with them, right? It shouldn't be, once a year meeting to tell them what you're doing, but maybe on a weekly basis, sit down with them, understand the questions, perhaps go to the OR, perhaps, go to their office and sit down with them and understand the questions, and then go back to them with solutions and say, this is what we propose, this is what we've come up with, what do you think? And that's where, translation also starts to happen, because these things don't happen in silos, right? It's not a paper, it's not a publication, it's not a grant. It's, if you want to have clinical impact, then you need to work together where you understand the problem, you come up with a solution, you go back to them and figure out how to translate it together in clinical practice.
Thank you for anticipating my next question, which was to ask you to dig in a little bit on how it is that you gain that understanding of the clinical question. I was wondering if we could hear from one of our clinical focused folks on how they gain an understanding of the technical questions that might affect the workflows, the processes that they're questioning.
Yeah, I'm relatively new to to AI, and it's hard because you only have a limited amount of time, and yet it's such a vast amount of information to learn and to try and get information on. I think there's a lot of hype around AI, and there's a lot of anticipation of what it potentially could do for us in the clinical space. And I think that in order to have a good understanding of that, I think you have to, try and gain an appreciation for the underlying principles and the underlying issues involved with data and that type of thing. And I would agree that there's a lot of different ways that you can go about doing that. And personally, I have done and utilized a lot of different avenues. I think the key thing, though, is to just have the interest and to just keep trying to tap different resources. I've done, some free, courses online. AMIA, is a great resource for trying to gain a baseline level of knowledge. And I found that as I learn, you start to understand and you start to hear things differently just because you do have the terminology, and that leads you to pursue different avenues as well. So I think it's very much of a learning process. Sometimes it's easy to get overwhelmed by all that there is to learn, but I think the key is to just start somewhere, and your interests and the people around you will help guide you. And I think the one thing that we do have to offer is that we are what people would consider to be the subject matter experts. And I think having an insight into where you can see how these tools may help us, and where, the effort would be worth, what they say, the juice is worth the squeeze. I think those are interesting questions that, we're all at the beginning of trying to figure out.
Sure. One more question on training, and then I want to move on a bit. So Shreya, I was curious, can you tell me about your learning journey, and how did you select genomics as your area of focus?
I can start from the very beginning. I found my interest in computational biology when I started my master's, and I started my master's thesis over there. And there I found I was very interested in this area, and I wanted to develop algorithms for genomics and all. So I decided to pursue this particular subject in my PhD also. And then I wanted to majorly build algorithms or methods that relate to biological problems. So every project that I have engaged with has provided invaluable learning experience, whether it was a major project or a side project, and regardless of the extent of my contributions into them. So and then I had this in mind that I wanted to work in AI in healthcare also. And that's where I started working with my husband. And then we both started working together with BrainX as trainees. And then it went on. So that's how I selected my areas of interest.
Sure. I feel like BrainX is going to emerge as a theme in facilitating a lot of collaboration. So that actually brings me to my next slide. So we wanted to talk a little bit about research and collaboration in healthcare AI. But first, I was going to ask Shreya if you would mind digging into this image a little bit for us. Tell us what it is that we're looking at here.
Okay. So this is time series plot, which tells you the gender bias in various fields of AI, ML, and computer vision, and computational linguistics over the time. And it tells you how women are incorporated in the field over the time. So I think the graph also tells us that women over the time have engaged more, and the bias is decreasing.
This is tremendously encouraging. Like when I saw this, I had a brief moment of like disbelief. Like this is almost truly too good to be true. I'm curious to know, our funded research, right, often requires collaboration across fields of study, across institutions. I would love if we could talk a bit about any barriers to collaboration that you might have experienced or observed.
Is this for me?
It can be for anybody.
Okay. So I'll start.
Sure.
Talking from my experience, because I'm a newbie because I just started postdoc, and so for a PhD student, collaborations don't come that easy, because it's the PI who does the collaboration and everything. PhDs are just a part of it. And what I feel is most of the PhDs work in silos, and they don't want to come up and talk to their PIs about collaborations, even if they directly want to do it. So I would say we have to talk to our PIs about it. And yeah, internships are very important in PhD. So,
sure.
Yeah, thank you.
Pallavi, can I ask for your perspective on barriers to collaboration that you may have experienced or observed?
Yeah, sure. So I think things were slightly different, I want to say 5 to 10 years ago, and it's certainly changing. But a big barrier has been data sharing, right? And not necessarily from people's perspective, but institutional perspective. You know, institutions are very protective of their data, and from you know, AI perspective, you need data. As much data as you have, more robust your models are going to be, more reproducible they're going to be. But because, you know, institutions are not comfortable sharing data, there's just so much paperwork that's involved that very often that, you know, you get discouraged and, you know, say, okay, it's going to take 6 months to do this IRB, to finish this paperwork, you know, probably, you know, I'm going to focus on something else. And so that's been a big barrier. But having said that, I do think that it's changing. People are recognizing more and more that, you know, it is healthcare. AI and healthcare is team science. It has to be together, and everyone's recognizing that. And because people are recognizing it, they're becoming more open to sharing data. So there's more effort happening in making data sets available publicly, but also sharing data amongst collaborators, amongst institutions. And I think that hopefully will continue to change in the next coming years.
Yeah. Lama, can I get your perspective on collaboration?
Yeah, sure. I completely agree with both points in terms of, I would say, number one, for us being used to working in silos, and then the other part as far as data sharing. And I think that boils down to the main barrier being the culture. So we've always been used to, the culture of research or clinical research, I would say, or healthcare research has been primarily more into people working in silos, and silos could be, just the clinicians working by themselves or specific institutions or specific departments that are working by themselves. And we rarely used to incorporate other disciplines within our research teams. So it could be just the healthcare team working together, or just the data scientists working together, or just, certain groups that are working in silos, or just my institution working together, or my institution and other institutions. So I think that used to be, and that's a big part of the culture that was going on in terms of clinical research. Part of it is just the way, people feel more comfortable working with their own groups. And then the other part was related to data sharing, that there was a lot of those issues of, there's a problem of sharing data and, compiling data or bringing data together. I think now things are really progressing at a much, much better stage and much better fashion than it was before. So we clearly realize that there is absolutely no way you can do AI in healthcare working in silos. You have to work with a very diverse team, and you have to work with a very general, that team has to be representative of not just the area that you're in, but it has to be representative also globally if you're looking at a high impact AI healthcare research that you're doing. And then the other part related to data sharing, there's really that big push from everyone, whether it's industry, whether it's reviewers, whether it's journals, whether it's institutions, to really go with open access. And there's a lot of mechanisms to kind of overcome those issues of privacy. So that concern about privacy, there's a lot of mechanisms to overcome that. So I think, again, it all boils down to that culture that we initially had. But I'm very happy that, to say that things are changing and people are realizing that that culture does need to change. And it changes at different, that pace will change, will differ depending on the institutions. But I think we are moving in the right direction of really helping that collaboration expand.
Yeah.
Jennifer, just one more point to add to this which I think is important for us to discuss here, is this issue of diversity in data, right? So if you're training your models with just Caucasian population, you can't expect the model to work well with other populations. And so, openness in data sets also allows us to build models that are more robust and can account for these challenges. In fact, in our own research, we've shown that we know cancer response is different for men and women, right? But we don't necessarily take that into account in the research. And so if you train models separately for men and separately for women, you can start to sort of pick out differences, sex-specific differences, and same is true for racial diversity as well. And there are many, many, excellent works in this space where people have demonstrated that the signatures of response for African-American women is going to be different from Caucasian women, it's going to be different from Asian women. So, if we have data sets that are diverse, it allows us to really be mindful of that while we are training the models. So it's important to recognize that as well.
It's a really crucial point, and one I'm glad you brought up. I think about this a lot at Cleveland Clinic, when we're thinking about our data set, and I'll let Reem talk about this because, you're much more in the know about it than I am. But I think about, we're a large tertiary, primarily cardiac surgery, institution. We have a very different patient population than a hospital system that is primarily engaged in providing primary care and specialty medical care. Reem, I don't know, any thoughts on bias or on collaboration? I've taken us on a tiny bit of a tangent.
Yeah, no, I would agree with that, and even within the Cleveland Clinic, we have a lot of different pockets of different types of, patients, and finding a way to unify, all that together is really quite challenging.
So I want to take us back and get us back on topic, because I am going to go dig through the BrainX archive for more information on bias and diversity in data sets. I wanted to go back and talk about collaboration, and I wanted to think not only about peer-to-peer collaboration, but also mentoring relationships, right? So, Shreya, you talked about, PhD students needing to work through their PIs for collaboration. I'm thinking about the stats we saw on our first slide, where we've got 20% of students, or less than 20% of students in data science are women, less than 10% of the decision makers are women. If we're trying to get collaborative relationships set up and mentorship set up, any advice for how to build and maintain those kind of vertical collaborative relationships as well as peer-to-peer collaborative relationships? Because I'm really curious, how do we make sure that our new generations of female students in data science, how do they get the mentorship and the assistance that they need without the four of you personally mentoring literally everybody who comes through?
There are two ways. You can always so in my institute there was a option of taking up an independent study where you could collaborate for a semester with other professors in the department or in the institute, whosoever you want to, or you are interested in their research work. So that leads to one collaboration that you can start and maintain, and then you can also think about working as a teaching assistant for other professors. That I also did, and that relations or collaborations went on so good that that I got very good recommendation letters from them. And secondly, there are some mentor-mentee relationships that within the PhD circles, where you can collaborate with your PhD peers or seniors, and you can work with them and learn a lot from them, from their experiences. Yeah.
Thank you.
Maybe I would just add one more point to that. I think that's a great model that you're describing, Shreya. And maybe one other point that I think for anyone kind of a clinical researcher in this field, and again, that's part of kind of the culture change, is to really think about or make sure that we have students incorporated within our research team. And that's really a great way of getting them to learn, getting them to also learn how to mentor, because that student could be in that research for the first time, and then the second time they're in, maybe they're mentoring another student. But it's really a wonderful model that that I've used with the last few projects that I've worked on, where we have a group of students that are part of that research, and we actively recruit those students to be part of that research. And it's different than how we used to do research in the past. We used to just feel that if a student wants to be part of research, they can just hop on and they can be part of it. So it was not something that we actively seek to incorporate within our research team. But we're looking at it differently now, that we need to have students and we need to have junior researchers as part of our research team. They're very enthusiastic. They're really willing to learn, which is great. And it really helps with that, what you mentioned earlier in terms of expanding that pool of people that can really move this forward. So it's part of that culture change, I think, of how we look at the research team and how we look at mentoring.
Sure. Pallavi, Reem, thoughts on mentoring?
Yeah, one thing I would say, just from my own experience, and I have quite a few female trainees in my group, so something I'm quite proud of. But to that point, I think creating an environment where your trainees feel comfortable sharing, their vulnerabilities, and same goes the other way as well, right? You don't want to create this sort of distance where they're not comfortable sharing their challenges, and they feel like they have to deal with problems, rejections, which is very common in research, right? We all have those rejections. We all have those days where we put in so much effort in writing a paper, writing a grant, and it doesn't come through. And I know that students have the same issues. So just for them to feel comfortable and come to you and say, these are the challenges I'm dealing with, both from my research perspective, but just otherwise as well, because PhDs, you spend a long time with them and then they're part of the group. So, and for me, I learned from them as much, probably more than, what they learned from me, because this field is growing so quickly. This AI space is growing so quickly. There are new architectures, new models coming out every day. that they come and tell me, Pallavi, there's this new model that I want to try. And so just creating that environment really makes a big difference, especially if you have female mentees where they can come and talk to you.
Sure. Reem, any thoughts?
Well, I guess the one thought that I would say is that, I mean, in order to establish relationships, you first need to meet people, right? So I think having, participating in communities like BrainX and, finding other venues where you can meet, like-minded people would be the first step. And then, once it's just the whole networking from there. You know people, they're interested in this. And I think, because it is so new and it is not a big group, I think you do need to actively, look and try to meet people and grow your network.
Yeah. A policy question. Last question on this topic. So, we've got this decreasing gender bias over time. If you were going to create a policy or make a suggestion to accelerate that reduction of gender bias, anything that you might consider?
Maybe I can provide some perspective.
Sure.
So at least based on my understanding of where it starts to the gender bias starts to happen and the model starts to fall apart is around, I want to say middle school, because there's research that suggests that when, kids are in their kindergarten and in the elementary school, they have both, girls and boys have the same amount of interest in STEM. In math and science, and at some point it starts to sort of wane off, for for whatever reasons, peer pressure. I that's something that still needs to be studied. But perhaps what we need to do as a community is reach out, to girls in middle school and sort of start to make sure that we start to have impact where it starts to fall off, right? And show them they're women scientists. We are cool people doing awesome research. And start to sort of propagate this idea that scientists are being in science and doing science is still cool and interesting.
All right. Anybody have any other thoughts? I'm sorry I asked you to come up with policy suggestions on the fly. All right. Shall we move on to our next slide?
I will say one more thing about policy, because I have quite a few female scientists in my group, and some of them are mothers, and I'm a mother myself. So just sort of providing some leeway, in terms of the needs that they have, which is a big challenge in America in general. So not something we can address over a podcast, but it's still worth mentioning, and worth mentioning that we all have similar challenges when it comes to childcare and issues surrounding it. So definitely having more detailed discussions around it, how to make female scientists, provide them with the right resources so they don't feel like they're alone, and also helping them get better access to resources.
It's a great point. All right, I believe our next slide focuses on implementation. So there's a lot of discussion about AI in healthcare. There's a lot of, like news stories, a lot of electrons and digital ink spilled on this. But I want to first talk about what's actually what's actually happening in the hospital. So it seems like medical AI device adoption is still pretty embryonic. There's a few leading devices that have gained some broader acceptance, but I would like to know our perspectives on implementing your work in a healthcare setting. And I think for this, I'd like to start with Reem and Lama. Do you have thoughts that you'd like to share?
One thing I would say is that I think there are areas where we are actually using AI and different algorithms. We may not perceive that as clinicians, but certain devices that we use, do use AI, and a lot of people may not be aware of that.
My apologies, I did not mean to interrupt, but I think about like imaging, right? I think about noise reduction in CT scanners. We already have a lot of AI in our healthcare. Please do go on.
And I think too, it also depends on what do you consider machine learning. Where we are, familiar with using, risk prediction scores and things like that. And I think, the question, and if I've done a lot of reading, just, the research to try and see, what's been actually implemented. And there's a lot of, publications and stuff about, we developed a model for this, we developed a model for that. But I think the question is how do you put that in the hands of clinicians? How do they understand the best way to use these tools? And how do they have the information that they need in order to allow AI to help them? I think the role of AI, there's a lot of anxiety about it. Is it going to replace, clinicians? And I really think, and then you also have the issue of, will people become overly reliant on something that they don't necessarily understand? So I think there's a lot of questions. I think there's a lot of research, a lot of work that needs to be done. I think the ultimate answer is going to be, what is the best way for AI to supplement what we do as clinicians, just help support us, because the complexity, the change, the questions about regulations, there's just so many outstanding questions right now. It really makes it quite difficult.
Lama, do you have thoughts to
Yeah,
share?
I completely agree. There's certainly a level of AI that we're already using in our practice, and in terms of machine learning and prediction models, I think in the ICU setting, a lot of our work is actually about predicting, even though we don't, we're not officially going through that machine learning process, but it's all about predicting what the likelihood of that patient surviving or improving or what. So there's a lot of prediction that goes into our decisions as we are in clinical practice. But I think the part related to kind of the full-blown or more higher level AI and machine learning, that's the part where I think there's the element of fear that Reem mentioned for the several reasons that were mentioned in terms of what people perceive as far as AI in healthcare. But then there's the other part that we're starting to realize more over the past years, that there's actually bias within a lot of these AI developed tools. And part of it has to do with the data that's utilized to develop those AI tools or those prediction models. And so people are taking a step back and saying, is that AI actually improving the quality of care that I'm giving to my patients, or is it further amplifying potential bias that already existed within healthcare? So that's kind of, I think, a large part of what's going on in terms of that fear element that Reem described. And then there's the concern about the bias that's really holding people back. And I think the more we're learning about AI and healthcare, the more we're realizing that, we really do need to take a step back before we kind of move in that direction at full scope.
A great point. Pallavi, do you have thoughts on implementation of AI in healthcare?
Yeah, so it's a very tricky subject, right? Because the field is growing quickly. There's a lot of work happening in this space, but we are still struggling to implement the AI tools into clinical practice. And so we are trying to do it here at our institution. And there are, this developing the AI, validating the AI is one aspect of it. But then implementing it is a whole different beast, where you have to figure out how to connect with the IT infrastructure and how to get the images into your model. If it's a cloud-based model, how does that speak to the IT infrastructure, in the hospital, in the radiology department, or whatever kind of data you need. And to make that connection is non-trivial because of, security issues and a whole bunch of other issues that we need to be mindful of. So that's something we are still trying to figure out. And if people have solutions, please reach out to me, because I'd love to hear from them. But I'm hopeful, because the field is growing so quickly. I'm hopeful in the next year or 2 years, we will start to see a lot more of these AI approaches that will start to get translated into clinical practice. And that's really where it, rubber hits the road, right? You want to make sure that, these algorithms are being implemented, but then also, like to Reem's point about understanding how good these models truly are, just beyond the paper and the publication. And if they're not good, they're not going to be used. If they're good, they're going to continue to be used. So that's where I think in the next 3 to 4 years is where I'm hopeful that the field will go.
Shreya, talk to us about implementation.
Yeah, so I think data privacy and security is a big concern in a healthcare setting, and with large language models in place, there's an advisory that you do not pass the data directly to the to ChatGPT, because that's the advisory for Mimic 3 also. You cannot pass the data directly to it. You have to use Azure. And I think that's the major concern. And secondly, there's this computational support. Large language models right now need a lot of computational support that makes them difficult to be deployed. So you need cloud for that, and then it becomes cumbersome and difficult, and like Dr. Tiwari said. So yeah.
So Pallavi, you called out a barrier to implementation that I wanted to go back and kind of discuss a little bit about your healthcare IT group. Actually, now you've got a validated model, you're feeling very confident in it, and now in some ways you're starting over from square one, right? You're bringing in a product into an ecosystem. It needs to be evaluated. It needs to be, like revalidated using, that healthcare system's data. I'm curious, Reem, I know you and Piyush and I have thoughts on this. I'm in year 2 of an implementation myself. So I feel your pain. I have no answers. I only have sympathy. But I'm curious to know, in addition to healthcare IT groups, in addition to compute power, are there other barriers to implementation? And are there ways that your institutions could support your innovations?
That's a good question. What are the barriers? I mean, right now, the biggest barrier that we are dealing with, because we are doing it in real time, is just sort of trying to figure out the IT connections. And so maybe one more thing that I could talk about and discuss here is dissemination, right? How do you disseminate the validated model? It could sit in, I wouldn't call it truly validated, because it's validated on retrospective data, but not on prospective data. So yep. How do you validate it on prospective data? It could either sit on research packs, right, as a first step, which is, again, it's not easy to do, but doable. And then there is another aspect, which is, going back to Shreya's point about computational challenges. Most likely it is going to be an algorithm that sits on the cloud, so you can do extensive computation on it and then send the results back. But if it's sitting on the cloud, then there is that connection that needs to happen between the EMR or the radiology, MRI scans, or whatever kind of scans need to be fed into the cloud. And that's where I think it's we are still figuring that out. At least on our end, we are trying to figure that out. But I know that I'm hoping in the next year or 2 years that becomes a little bit more seamless. But in my mind, I think that's a challenge that we need to address sooner rather than later.
You raise a really good and a very subtle point about a validation on retrospective data being very different from validation on prospective data. I know, Reem, I don't know if this plays into any of your thoughts on implementation.
Well, yeah, I think, we all know that the data in the electronic health record is definitely not clean, right? Like there's a lot of issues with that data, and the data that these models are trained on, is going to be different than the data that they're actually going to be utilized on. So that's definitely a big issue. And then I think there's many barriers. One, like I said before, is education. 2 is, you need to set up some type of governance. You need to set up a way to monitor these algorithms. I think you need to find a way to address the questions and the issues that are going to come up, and then you're going to need to maintain them over time. And so you need to, and then if you look at a big institution, you basically have one pot of information that's going to be deploying many different types of algorithms that are good at many different things. So how do you manage all of that with the resources that you have? It's one thing to have a very targeted, algorithm that you want to put into a certain area, but then when you look from an institutional perspective, and you start layering all these things on top of one another and the resources that would be needed to maintain it, there's just a lot of interesting questions and opportunities there.
I agree. Lama, any final thoughts on implementation?
No, I think I agree with everything that was mentioned. And I think the more, I think this is one of the areas where the more collaboration between the teams would really help, because there's a lot that we don't see on the other side in terms of the implementation and the technical part. And there's a large part that the technical team doesn't see on the clinical side. So the more collaboration and the more group work, it really helps things flow much better in terms of being able to implement the systems.
Sure. All right. I wanted to move on to our next slide because this is one part of the discussion that I'm really looking forward to: misconceptions in healthcare AI. So I hear a lot of fear about AI replacing doctors and other clinicians. I hear a lot of fear about, putting ourselves out of a job. And I also hear fear that people will rely on faulty or biased AI tools, right? We're going to put this thing into place and it's only been tested on, like middle-aged white dudes. No disrespect to middle-aged white dudes, but if your outcomes are much different for other populations, then your algorithm is not super great. So I would love to hear if you could debunk just one misperception about healthcare AI, which one would it be and why?
I think, the one, maybe not necessarily the one that you've mentioned there as far as replacing doctors, but maybe the one that was really emphasized at a more global level is that AI in healthcare will actually improve the quality of care at a global level. So even in resource limited countries, that this would really help provide better care, better guidance in terms of how you would interpret the CT scan, and better guidance in terms of how you would manage patients, and that it would really revolutionize the healthcare in at a global level, and again, specifically in low middle income or limited resources settings. And I think we're realizing now that this is a huge misconception and we're far from getting there. I think we're on the way and we can certainly get there, but I think we're far from getting there in terms with the way things are structured at this point, and especially with the lack of data representation in most of the AI models and most of the AI tools that are being developed. So that's probably the one. There are 20 others, but I think that's the major one that I would share at this point.
Yeah, I would agree with that. I mean, people aren't really even sure that the electronic health record really improved care. I mean, that's debatable right now at this point. I think another misconception is that this is going to happen quickly. Everybody talks about how, oh, the pace of this is so fast, and before you know it, we're not going to have time to adjust. I don't think this is going to happen as fast as everybody is anticipating.
I would actually pick two, if that's okay.
Sure. There's no rules.
And I'll go to the two extremes, right? So first extreme is AI can do magic. No, it can't. There are people who, think AI can do anything, right? That's not the case. Especially AI in healthcare. You have to be very careful with what the problem, and again, I go back to problems, understanding the problems, figuring out solutions. So there's a lot more that goes into it. It's not some magic, data-driven sort of throw data at it and let it figure out what it can do. So that's one misconception. And the second one is the fear, right? And again, to Reem's point, it's not going to happen quickly. I don't think we need to fear it. We're not at that point, especially, again, I don't know about the other fields, but definitely not in healthcare AI, right? So not to say that we don't have to be careful, right? We have to be very careful with how we train models. We are becoming more and more aware of the challenges with ethics, which we've discussed, but it's not something that we need to fear. And I remain bullish about what AI can do in healthcare. And I know it can do a lot of things, but if we fear it, either if we think it does magic and it doesn't do magic, that's disappointment. And if we think it, if you fear it, we are just not going to be acceptable of what it can do. So, it's somewhere in the middle where, it's not, we don't have to fear it, but at the same time, we don't have to just sort of blindly believe that it can do magic.
Sure. Shreya.
Yeah, so I have heard people saying that augmented reality, virtual reality, they are going to replace surgeons, and it's AI that will do surgeries now. So I would debunk that. And I would say AI, there's a long road ahead of us. And AI can right now complement and enhance human capabilities. And rather than they cannot replace humans entirely. And then there is this bias that you talked about in the AI models, and so it's gonna take a lot of validation on those models that we will implement in real world setting.
Yeah. If I can add my own editorial bent, I think my misconception that I would love to debunk in healthcare AI is that health data sets are clean or objective in any sense. The healthcare data sets, A, are terrible, and B, they reflect the biases inherent in the system, right? And so I think we need to be very thoughtful when we're choosing our data that is going into these models, because with pickled data and an AI model, you're just going to get garbage out. It's not going to do better than any clinician. So last question and last slide, and then we have some excellent questions from the audience that I want to hit. So I would like our panelists to take a victory lap. I would like you to tell me about, you can choose either one of two things. One, what are you most proud of so far in your career? Or two, what are you most looking forward to accomplishing?
Well, I'm looking forward to, oh, sorry, go ahead. Oh, I'm just looking forward to continuing on this path. I think to some of the things that we've talked about, you feel like, oh, I'm late getting into the game, and I'm so far behind. But I'm proud of the work that I've done so far and just educating myself, and I'm looking forward to trying to find a way to participate in the journey, that is AI going forward in healthcare. So that's what I would say. Right, Lama.
Yeah, I would say, I'm certainly proud to be part of the AI journey. I still have a lot to kind of add to my plate, but maybe the part that I really would hope that we would be able to achieve collectively, as healthcare practitioners, is to really be able to utilize AI to proactively prevent harm that may occur during the healthcare journey of patients. So patients come in, for example, I deal with a lot of oncology patients. They take their chemotherapy, they develop complications, they come into the ICU. Patients present to the ICU with a complication, they develop something else. A lot of it could be iatrogenic, and then things just go in a completely different direction. Ideally, what I would hope at one point is that we're able to predict that more proactively and be able to prevent that using AI. As I mentioned earlier, a lot of what we do is about predicting, this patient is probably would not do very well with a heavy dose of chemotherapy, so let's do a lower dose. So we try to kind of clinically make those assumptions, but it would really be helpful if we have the AI tools that can really support that clinical decision and say, well, maybe you shouldn't be giving chemotherapy to that patient at all, because that patient has a 90% chance or a 95% chance that they would present to the ICU and die from sepsis. So it's really where I would really hope that those AI models will help us in preventing some of the harm that we induce as we are taking care of our patients, or as the patients are going through their journey.
Yes. Shreya.
So yeah, there's no such project that I'm proud of. I'm proud of all the projects that I do, yeah, even if the teeniest one. Yeah, and in future, I would like to see my models being implemented in a real world setting or a healthcare place. Yeah, that would be a proud moment.
Pallavi, take us home.
Yeah, so the proudest thing I would say is, perhaps the opportunity to mentor students and trainees. I'm quite proud of that, proud of the team that I have and the work that we all get to do together. This is sort of the next generation passing it on so they can pass it on, and sort of, that chain that hopefully continues to grow, and especially going back to contributing a little bit to this the plot that you shared, where we have such few women in AI and healthcare. And so my little contribution to that, where I seek to mentor more female students, mentees, and then they can go on and pass it on and get more and more women involved in this field, and that's in this space. But one thing that I'm really looking forward to, actually two things, and then both of them have been addressed before by previous panelists. In the near term, really looking forward to implementing some of these approaches that we have developed into clinical practice, and I'm hoping that can happen sooner rather than later. And the second point that Lama made about personalized medicine, I think that's really where I'm hoping we can go with AI and machine learning, where we could start to make clinical decisions based on a patient's profile, their risk profile, their assessment, instead of saying, everyone gets chemotherapy because that's what we know. Right. So that's what I'm hoping we can use AI going forward in that optimal fashion for every patient.
Thank you. So we are running very close to the end of our time. Just in case I don't get a chance to, I want to thank each of our panelists for taking time out and contributing to this wonderful discussion. I have learned so much today. I am so excited to go back and do more research and to continue this conversation. We have time for maybe one question from the audience, and there's a few on a similar theme that I kind of wanted to pick out. So I would love if we could talk briefly about methods for detecting and mitigating bias, both in your preliminary training data sets and in the outputs of your algorithms.
So maybe I could start. So I was mentioning, we did the study where we were training a model, we call it an all-comers model, where we don't take into account the racial biases or sex-based differences. And when we tested the model separately on men and separately on women, the model didn't hold, right? And so sort of understanding the data and appreciating the biases, it allows you to be more mindful of how you're training the model itself. It's the same idea with garbage in, garbage out, right? If you have garbage in your training sets, your output is not going to be meaningful. So just being aware of what the data sets look like and being mindful of how you train the models is helpful, especially when it comes to diversity and taking that into account. And I've seen in other works as well, where when people have trained models that are more specific to certain races and certain populations, that the models tend to be more precise, especially when we sort of start to talk about developing models that start to address questions about precision medicine.
Lama, did you have thoughts?
Yeah, I was just going to say this is like a monster question with a monster answer. But it's very difficult to really determine exactly what's the best approach, or what's strategies are best to mitigate the bias, because I think it starts by us recognizing what the sources of bias are, and I don't think we clearly understand all the sources of bias. So unless we understand them, it's very hard to say, well, this is what we're going to address and this will mitigate the sources of bias. a lot of the data and a lot of the literature that talks about sources of bias actually comes primarily from the US and from Europe. And they've identified, for example, underrepresented populations, whether it's, for example, females or, Black patients or, certain ethnic groups. And that applies, for example, to the US, but it certainly doesn't apply for Jordan. It doesn't apply to many other countries within the global setting that we're looking at. And it may or may not be incorporated within the data sets to begin with. Part of it is that we may identify what certain elements we're looking for so that we can eliminate bias, but those may not be included in the data set to begin with. So we can't address them. That's one part. But then the other part is we may not know exactly what the elements of bias could be or what underrepresented populations we have and what groups we need to target. And so we're kind of in an unknown, it's completely unknown at that stage. So I think the first important step is that we have to be proactive in terms of trying to identify what are the potential sources of bias. So taking a more proactive role. And I'm part of an initiative which is called the Standing Together Initiative. We're working on certain criteria in terms of what really needs to be incorporated within the data sets as the data sets are being developed and what needs to be addressed as far as underrepresented patient populations so that the data sets to begin with have incorporated those elements. But again, even within those criteria, it's based on the literature that comes primarily from high income countries, and it doesn't really reflect the entire global field. So again, I think it's important to recognize that, to proactively try to identify it, but recognizing also that we won't be able to eliminate all those sources of bias. So we have to be proactively assessing the models and making sure that they're validated so that if there's any additional sources of bias that we kind of address them at that point.
Being thoughtful and proactive seems like an excellent point to end our discussion on. Piyush, can I turn it back over to you? Thank you again to all of our panelists. This was wonderful.
Yeah, thank you, Jenny, for your excellent moderation, and thank you all the panelists and some excellent discussion that has been going on in the chat. I'll say, in my unbiased opinion, this is probably one of the best sessions that we have ever held. And I have the evidence for this. You all know it's very difficult to keep me quiet for 1 hour on healthcare AI, and you successfully did that. So thank you very much. It was a great learning experience. I think all of us learned a lot from that. Hopefully, a lot of participants and others who view this later will reach out to you. Hopefully, we will be able to get a lot of people to join together across different communities. And that was the purpose of forming BrainX Community. So thank you, everyone, for joining us. We'll end the session now. Appreciate everyone being here. Until next time, take care.